It usually begins with something so ordinary that most people barely notice it. A burning sensation behind the chest after dinner, a sour taste rising into the throat, a strange feeling that something is coming back up when you lie down at night. For millions of people, it is dismissed as simple heartburn, but then it starts happening again and again. Perhaps the person is young, they exercise, they are not obviously overweight, they do not have a serious illness, yet suddenly, meals are followed by discomfort, sleep is interrupted, and the question becomes impossible to ignore. Why is this happening? GERD, or gastroesophageal reflux disease, is no longer a rare digestive problem confined to a particular type of patient. A large global analysis published in 2020 estimated that roughly 14% of the world's population had GERD, although estimates varied dramatically between countries and depended heavily on how the disease was defined. And that variation is our first clue. Because the mystery is not simply why stomach contents sometimes move in the wrong direction, the mystery is why a system designed to keep them in the stomach appears to be failing or becoming symptomatic in so many different people. To understand that, we need to go inside the body. At the bottom of the esophagus, the tube carrying food from the mouth to the stomach, there is a muscular region known as the lower esophageal sphincter. Think of it as a biological doorway. Most of the time, it stays closed. When you swallow, it relaxes long enough for food to enter the stomach, then closes again. That sounds simple, but the digestive system is not a simple machine. The stomach contains acid powerful enough to break down food. The esophagus is not designed to be exposed to that environment repeatedly. When stomach contents move upward, the body normally has several ways of dealing with it. Swallowing clears material back down. Saliva helps neutralize acid, and the barrier at the junction between the stomach and esophagus limits how much can come back in the first place. Occasional reflux can happen even in healthy people. That is important. Reflux itself is not automatically a disease. GERD is generally considered a condition in which reflux causes troublesome symptoms or complications. In other words, the medical mystery is not simply, why does acid move upward? It is also, why does that reflux become frequent, severe, or damaging in some people? And that distinction changes everything. For decades, researchers have watched the prevalence of reflux symptoms rise in many populations. A systematic review examining time trends found evidence that GERD prevalence increased over time, particularly in North America and Europe. Another review published in 2014 found evidence suggesting that prevalence had increased since the mid-1990s, although the scale of the increase varied between regions. So something appears to be changing. But what? The obvious suspect is weight. As obesity has become more common in many countries, GERD has also become more common. A large meta-analysis found that obesity was associated with higher odds of reflux symptoms, with obese individuals having substantially greater odds than people who were not obese. There is a biological explanation. Extra abdominal pressure can increase pressure inside the stomach and affect the barrier between the stomach and esophagus. That can make it easier for gastric contents to move upward. But here the investigation takes an unexpected turn, because obesity cannot explain every case, not even close. There are people with GERD who are not obese. There are young adults with reflux. There are people who develop symptoms despite having no obvious change in their body weight. And there are people who experience severe symptoms even when doctors cannot immediately see major damage inside the esophagus. That means the story cannot simply be reduced to one lifestyle factor. So investigators began looking at the modern environment around us: what we eat, when we eat, how much we eat, how we sleep, which medications we take, whether we smoke, how our bodies store fat, and even how our perception of symptoms may have changed. Some associations are supported better than others. For example, the global meta-analysis found higher prevalence of reflux symptoms among smokers, people using certain anti-inflammatory medicines, and people with obesity. But the researchers also emphasized that these associations were relatively modest, and prevalence varied enormously depending on geography and diagnostic criteria. That matters because it is very easy to turn an association into a dramatic explanation. Coffee causes reflux. Stress causes reflux. Late-night eating causes reflux. Spicy food causes reflux. Modern life causes reflux. Some of these ideas may make sense for particular individuals, but population science is messier. A factor can trigger symptoms in one person without being the universal cause of a disease. And this is where the GERD investigation becomes much more interesting. Because perhaps the question is not, what are people doing wrong? Perhaps the better question is, what has changed in the relationship between the digestive system and the world around it? Consider the sheer scale of the problem. A 2020 systematic review covering 102 studies from 37 countries estimated global GERD prevalence at about 14%, while also finding enormous regional differences. North America had one of the highest pooled estimates, while some Asian populations historically showed much lower rates. That geographical difference raises another question. If GERD were caused by one simple behavior, why would entire populations experience such different levels of it? Genetics may play a role. Body composition may play a role. Dietary patterns may matter. Smoking, alcohol, medications, anatomy, and other environmental factors may contribute. And there is another possibility that researchers have had to take increasingly seriously. The disease itself may not be one single biological phenomenon. Two people can describe the same burning sensation, yet the underlying mechanisms may be different. One person may have obvious acid exposure damaging the esophagus. Another may have reflux without visible injury. Another may have symptoms that overlap with a condition involving heightened sensitivity of the esophagus. And this is one reason GERD can be surprisingly difficult to diagnose and understand. The symptom is real, but the mechanism behind the symptom is not always obvious. Modern medicine has therefore moved away from viewing reflux as simply a matter of too much stomach acid. Acid matters. But the story also involves the barrier between the stomach and esophagus, the movement of stomach contents, the sensitivity of the esophagus, and the way symptoms develop. That distinction is crucial because it explains one of the biggest misconceptions surrounding GERD. The burning sensation does not necessarily tell us exactly what is happening inside the body, and the absence of dramatic pain does not necessarily mean there is no reflux. The digestive system is operating continuously, often without our awareness. Every meal triggers a carefully coordinated sequence of muscular contractions, pressure changes, and chemical processes. When that coordination works, we never think about it. When something goes wrong, we suddenly become aware of every swallow, every burp, every meal, every position we sleep in. And perhaps that is why GERD has become such a strange modern health mystery. It sits somewhere between normal physiology and disease, between occasional reflux and chronic symptoms, between obvious risk factors and people who seem to have none, between what researchers can measure and what patients actually feel. The evidence tells us that GERD is common and that its burden has increased in many populations. But it does not give us one universal culprit. And that leaves us with a more difficult question. If obesity explains part of the increase, but not all of it, if diet may matter, but individual foods cannot explain the global pattern, if medications, smoking, anatomy, and other factors can influence reflux, then what happens when all of these variables begin changing at the same time? Because the next part of the investigation takes us beyond the stomach. It takes us into the modern schedule itself, the way people eat, sleep, work, and live. And there, researchers have found some intriguing connections. But separating a genuine biological signal from everything we simply assume about modern life is where the real mystery begins. To understand why GERD may be becoming more common, we first have to find out whether the modern world is actually changing reflux, or whether we are simply getting better at noticing it. If the rise of GERD were caused by one simple mistake, the investigation would already be over. But the evidence points somewhere more complicated. The modern world has changed how we eat, sleep, work, and move. At the same time, medicine has become better at recognizing digestive disorders. So which explanation matters more? The answer appears to be a combination. One of the strongest pieces of evidence remains body weight. Obesity is consistently associated with a higher risk of GERD, and researchers have several plausible biological explanations. Increased pressure inside the abdomen can make it easier for stomach contents to move upward, while changes around the junction between the stomach and esophagus may also weaken the normal barrier against reflux. But even this explanation has limits. Not everyone with GERD is overweight, and not everyone who is overweight develops troublesome reflux. That tells us something important. A risk factor is not the same thing as a cause. The same problem appears when we look at food. People often blame individual foods for reflux: coffee, chocolate, spicy meals, fatty foods, citrus, carbonated drinks. Some people clearly notice symptoms after particular foods, but clinical research does not support a universal list of foods that every person with GERD must avoid. The relationship between diet and reflux is much more individual than popular health advice often suggests. There is a reason for that. A food may not directly create GERD. Instead, a large meal may distend the stomach. A high-fat meal may change how quickly the stomach empties. Eating close to bedtime may place a full stomach in a different position during sleep. And suddenly, the important variable is not just what was eaten, it is the entire situation surrounding the meal. This becomes especially interesting at night. When we stand or sit upright, gravity helps keep stomach contents where they belong. When we lie down, that assistance disappears. For someone already prone to reflux, nighttime can therefore become a revealing experiment. The symptoms may appear not because the body suddenly produces enormous amounts of acid, but because the physical conditions surrounding reflux have changed. And then comes another modern factor: sleep itself. Poor sleep and reflux can interact in both directions. Reflux can interrupt sleep. But disrupted sleep may also change how people perceive symptoms, affect eating patterns, and alter behavior the following day. Researchers have found associations between sleep disturbance and GERD, but this is another area where cause and effect can become difficult to separate. Does reflux cause poor sleep? Does poor sleep worsen reflux? Or do both arise from another underlying factor? Sometimes, science has to resist the temptation to choose a simple answer. Then there is stress. Stress is one of the most popular explanations for almost every modern health problem. But GERD provides a good example of why that explanation needs caution. Psychological stress does not simply switch stomach acid on and create GERD from nothing. However, stress can influence gastrointestinal function, symptom perception, and the way the nervous system responds to sensations coming from the digestive tract. This distinction matters. Two people might experience similar amounts of reflux, yet one may experience much stronger symptoms. The difference may partly involve how sensitive the esophagus is to what is happening inside it. This is one reason modern gastroenterology increasingly looks beyond acid alone. The esophagus has its own sensory system. When reflux occurs, the brain receives signals from that system. Sometimes those signals are associated with visible injury. Sometimes they are not. And sometimes a person can experience significant discomfort even when routine testing does not reveal the kind of damage we might expect. That does not mean the symptoms are imaginary. It means the digestive system is more complicated than a simple acid versus no acid equation. This is also where medications enter the story. Certain medicines can influence the risk of reflux or worsen symptoms in some people. Anti-inflammatory drugs, for example, can cause upper gastrointestinal problems. although their relationship with GERD itself is more complicated than a simple cause and effect claim. Other medications can affect the movement of the gastrointestinal tract or the pressure of the lower esophageal sphincter. But again, the lesson is not that people should stop taking anything. Medication decisions belong with qualified healthcare professionals who understand the reason a drug was prescribed, its benefits, its risks, and the alternatives. The larger point is that modern medicine itself has changed the environment in which digestive symptoms occur. People live longer. More people take long-term medications. More people live with obesity. Eating patterns have changed.
Sleep schedules have changed, and doctors now recognize conditions that may have been missed or labeled differently decades ago. So perhaps part of the apparent rise in GERD is a genuine biological increase, and perhaps part reflects improved recognition. The evidence suggests both may be happening. But there is another clue hidden in the data. GERD does not look exactly the same everywhere. Its prevalence varies between populations. Historically, rates were lower in many Asian countries than in Western countries, although the gap has narrowed in several regions as lifestyles and population characteristics have changed. That shift is especially intriguing, because when a disease changes as populations change, researchers naturally begin looking for environmental explanations. But there is a trap. Correlation can tell us that two things are moving together. It cannot automatically tell us why. If GERD becomes more common at the same time that obesity increases, that does not prove obesity explains the entire increase. If people start eating later and reflux becomes more common, that does not prove late meals cause the population-wide trend. This is why the strongest investigations combine several kinds of evidence. Population studies tell us how common the disease is. Clinical studies show what happens inside individual patients. Laboratory research can reveal mechanisms, and long-term observational studies can show how risk changes over time. When these lines of evidence point in the same direction, confidence grows. When they disagree, the responsible conclusion is uncertainty. And GERD contains plenty of uncertainty. One of the most important unanswered questions is why some people develop significant symptoms without obvious esophageal damage. Another is why some people with visible reflux experience surprisingly few symptoms. And another is whether the modern increase represents a single worldwide phenomenon or several overlapping trends happening at once. The answer may eventually be that there is no single GERD epidemic. There may be several. One connected to increasing obesity, another related to aging populations and medication use, another involving changes in diet and meal timing, another involving how the nervous system processes digestive sensations, and perhaps another involving how aggressively we now search for conditions that previous generations simply endured. That last point is easy to underestimate. Imagine someone experiencing heartburn 50 years ago. They might have called it indigestion. They might have changed their diet. They might have simply lived with it. Today, that same person may visit a doctor, undergo testing, and receive a precise diagnosis. That does not mean the disease is not real. It means the numbers we compare across decades are not always perfectly comparable. Definitions change. Diagnostic tools improve. People report symptoms differently. Healthcare access varies. Researchers become better at finding disease. So when we hear that GERD is becoming more common, the scientifically honest answer is not a dramatic declaration that one modern habit has caused it. The stronger conclusion is more subtle. GERD is genuinely widespread. Its prevalence has increased in many populations. Obesity is one of the clearest established risk factors. But multiple biological, behavioral, and environmental factors probably interact, and the relationship between reflux and symptoms is more complicated than simply having too much acid. That may sound less dramatic than a single culprit, but it is actually more revealing, because it explains why two people can live very different lives and still develop the same diagnosis.
and it explains why one person's trigger may not be another person's trigger. Most importantly, it changes the way we should think about the disease. GERD is not simply a failure of willpower. It is not proof that someone has eaten badly, and it is not always visible from the outside. It is a disorder emerging from the interaction between anatomy, physiology, environment, and perception. The good news is that medicine understands far more about this process than it once did. Doctors can distinguish occasional reflux from persistent disease. They can investigate symptoms when the diagnosis is uncertain. And there are established treatments for people who genuinely have GERD, with treatment decisions based on the individual situation. But the investigation ends with an important warning. Persistent symptoms should not automatically be assumed to be GERD. Chest discomfort, difficulty swallowing, unexplained weight loss, bleeding, or other concerning symptoms can have many possible causes and deserve medical evaluation. And no one should start, stop, or change medication based on a documentary alone. For someone experiencing ongoing reflux symptoms, the most useful next step is not to chase the latest internet theory. It is to speak with a qualified healthcare professional who can determine what is actually happening. Because perhaps the biggest lesson from the GERD mystery is this: the body rarely gives us one simple clue to explain a complicated disease. Sometimes the answer is hidden in the pressure inside the abdomen, sometimes in the barrier between the stomach and esophagus, sometimes in sleep, diet, medications, or body weight, and sometimes in the way the nervous system interprets signals that we cannot see. GERD may be becoming more common, but the deeper mystery is not simply why acid rises. It is why, in the modern world, so many different bodies are beginning to experience that rise in very different ways. And that is where the science leaves us. Not with a single villain, but with a much more useful conclusion. GERD is real, common, and increasingly understood, but it is also deeply individual, and understanding that difference may be the key to treating the person rather than simply treating the symptom.